Thank you, chairpersons. Thank you very much. And my utmost thanks to the organizers for giving me this podium to discuss this panel. After three excellent talks on these issues on uterine cancer, ovarian cancer, and cervical cancer by three very eminent speakers, we have understood what should be done for these tumors. And now my panelists will go on to say what we actually do in ground reality, because many of these things, as Sudeep also pointed out, is not a feasibility in our setup. I am given to understand that Dr. Preeti and Dr. Chetna Bakshi is yet to join the panel, but I believe they will go on joining as the time comes. So may I have the first slide, please? I think the slide is being presented. Sachin, you can present the slide.
Yes, sir. So, sir, we are giving you the control.
Okay.
Try moving it from your end, sir, by clicking at it first. And then. Yeah, I think so. They are moving, right?
Yeah.
Okay, sir.
Okay, our job is to ask a few questions. There are no data on this because we have had enough data in the last three sessions and we have understood. So we just go on to see how we do it in our clinics or how do we treat. So my first question, what sort of a mutation testing, BRCA testing would you like to do for your ovarian cancer? Is it a germline BRCA or a somatic BRCA? HRR or HRD, now all four are available. There are cost differences. What is and
hello, Dr. Goswami. Thanks for the question. Am I audible?
Yeah.
Hello.
Yes, Bhavna, you are audible. Please go
okay,
ahead.
Fine. Yes, yeah.
You are audible. Please go ahead.
Yes. So maybe a few years back, with family history of our ovarian cancer patients, or if they really had presented at very young age, we used to think of doing BRCA testing and all. But in last few years, the amount of data which has come out for PARP inhibitors and which has changed the landscape, the way our patients behave. At this moment of time, since last a couple of years, 1 year at least or 2 years, I would be doing BRCA testing for all my patients. And we also know that if at all you want to use PARP inhibitors as a therapeutic option, the results for somatic as well as germline BRCA are same. So you can start doing it in the tissue first of all, and if you find the result, and if you feel that you want to use the PARP inhibitor in various indications that of course can be discussed later on, then it is worthwhile. And of course, along with somatic, and then if it is positive, we'll also do germline, which will help us to even access the family members of the patient if at all they require counseling. Recently, now we also have understood that it is not only the BRCA. BRCA is just one or two. BRCA 1 and 2 are only two genes of the actual HRR mechanisms, where there are actually approximately 15 genes which are present in the gene panel of HRD testing. And we also know that these PARP inhibitors act quite well even in the patients who have HR deficient status. So now, of course, the time is right. We not only ask for BRCA, but we actually ask for HRD. That is my answer to this question.
Well, just to follow it up, is the cost of HRD testing is a concern in your practice?
Yes, certainly. And that is why, honestly speaking, my patients, more of them, they do BRCA because BRCA testing cost has come down significantly. Some laboratories automatically give package of somatic and germline BRCA, and that turns out to be much more economical. But academically, we all know that ideally we should do HRD, because if we don't do HRD, then we are going to miss out some cases those patients will still benefit. They might have a PALB2, they might have ATM, they might have
True.
RAD51. We do not
True.
know. Now, unless we really look for them, we are not going to offer treatment over patients. So I would prefer doing HRD, but honestly speaking, I am not able to do for all my patients.
Okay. Does any of my panelists have anything else to say than what Bhavna has already spoken? Does anybody has anything else to add to it, what Bhavna has said? I presume no. And since Preeti is yet to join, and I believe Bhavna has also all at this point of time. Am I correct, Bhavna?
Yes, I think we must test all our cancer patients. I think that will be definitely preferable.
Well, my next question goes to Dr. Kakoli, because you see, many of your patients may not be there at with you, so you may not be having the BRCA mutation status. So would you like to do the test at the outset for every patient, or will you like to do it whenever they come to you, or would you like to do it at relapse? Dr. Kakoli, please.
Yes. Right now, I mean, we would do actually as per the guidelines at the outset for all the patients. I mean, that is the ideal scenario. By any chance, if somebody had missed, like a few years back, if somebody, it was not done and they come at relapse, then of course we do as and when the patient comes. But
Yes, please.
sorry, yeah. So no, I have a bandwidth problem, so I cannot. If I switch on the video, you won't be able to hear me. Sorry. So somebody
you
was
can, you can put off the video for the time being, and you can put your
yeah. So that is what. So outset would be the ideal scenario. I generally recommend the testing at the outset to all my patients. And as we discussed, HRD is the ideal, especially with the Paulo data and Pezopenib now being generics being available. So HRD is the ideal setting. For some reason, if the patient cannot afford HRD, we do a tumor BRCA, at least a tumor BRCA. So for all the patients.
Well, any other testing, Dr. Suman? Do you have any other testing to be done? Do you think, looking at the future, looking at MSI, PD-L1, though immuno-oncology is not yet in an established frame of place in ovarian cancer, but do you think any other tests is needed?
Yes, sir. As you rightly told, it's not yet been approved. It's not approved by the FDA as such, but phase 2 trials are underway. And interim results look really promising for immunotherapy. So right now, the indications for using immunotherapy will be based on PD-L1. So it's prudent to do a PD-L1 testing if you are going to use pembrolizumab for these patients. And MSI, of course, if you are going to use the other drug which is approved. So these two drugs have been approved. So based on that, I would be tempted to do a PD-L1 and MSI also.
Well, two of our esteemed colleagues, Dr. Amit Agarwal and Dr. Smoothie, has already stated in the chat that it may not be useful to do BRCA in all those, especially mucinous histology and clear cell carcinoma, and PD-L1 and MSI are usually negative for ovarian cancer. Do our panelists have anything else to add on to what Dr. Smoothie and Dr. Amit has said?
Can I add, Dr. Goswami?
Please do.
Yeah, so I agree that the maximum number of this BRCA positivity or mutation or the HRD status will be found in high-grade serous carcinomas. But the others, the types of histologies also, it may be worthwhile at least doing this test. Because at least in the data which has been presented, even very, very small number of those patients also had this disease. Regarding the immunotherapy, the role in ovarian cancer is extremely limited, at least at this moment of time. So I do not do PD-L1 for my patients.
Okay. Coming to the next slide, please. Next slide, please. So coming to the maintenance therapy. Can you move the slide? slide is not moving from my end.
Sir, you can move it.
No, it's not moving from my end. If you can.
We are
move
not
it
able
from-
to see your slides. We are not able to see your slides, Dr. Goswami.
Now, the slide is being presented from the organizer's end, so I am not sharing
Oh,
my
okay.
screen.
Oh,
Okay, sir. Just a second.
Yeah, now it has moved. So coming to maintenance therapy first line, Chetna, has she joined? I don't think she has joined as yet.
No, sir. She's not in.
Okay, so do we need maintenance therapy for all or not? First line, I'm talking about first line ovarian cancer, all comers. Do we need maintenance therapy? I think Mohit, you can take it up.
As far I remember, I know about the guidelines that it is not required for stage 1 patient at least, we can say. And
Okay.
there is limited data for stage 2, but still we are using for the stage 2. So it's not for all comers, that's what I can understand. For stage 1, I think chemo alone is sufficient, chemo plus surgery.
Anybody else? Anybody else?
yes, I agree with what Dr. Saxena has said. Unfortunately, majority of our patients come in advanced stages. I mean, we have very few patients who
Yeah,
actually
yeah, yeah.
come in early stage.
So we end up looking at
Yes.
maintenance therapy.
Correct.
Now-
That's what I wanted to say.
Yeah. So Mohit, you carry on with now. Bevacizumab maintenance has become a standard of care in many of the situations after the studies have come out. Before the PARP inhibitor came into the picture in ovarian cancer in big time. So bevacizumab, in which cases do you think you use in your practice? And in your practice, how long? I am not saying what should be done, but in practice, how long you are doing it? How long you are giving the bevacizumab maintenance? Mohit, it's up to you.
What we are doing is that we upfront advise of course, we usually advise the BRCA, but ideally it should be HRD. And if the HRD is, say, negative, then, and if the bevacizumab is the part of induction therapy, then only I will use maintenance. That's one point which I would like to tell. Another thing is that strong data for bevacizumab is only for stage 3 and 4. We have guidelines that support stage 2 as well, but it is mainly stage 3 and 4 that is support the use of bevacizumab. Another point I would like to tell that the subset analysis of I think GOG trial says that in the patient with ascites, the addition of bevacizumab is more helpful in comparison to other patients. And if as well, based on the GOG 208 trial and ICON 7 trial, and I usually advise the patient if they are HRD negative, then I add the bevacizumab in induction therapy, and I suggest them to use for the say 15 months or say 22 cycles.
Okay.
That's in 15 mg per kg dose as per the GOG data. And if they are HRD positive, then there is data to add bevacizumab to the olaparib if they are already used in the induction regime as well. But practically, we hardly using in this subset. The Paula data says that we can use in that manner as well. And this is again for the say 15 months or say 22 cycles.
Well, Mohit has talked about 10 milligram per kg. Anybody in the panel using 7.5 milligram per kg? Anybody in the panel? Or all is using 10 milligram per kg bevacizumab? Well, if there is no takers for it, the next question goes to Dr. Sandeep. Part in which, sorry, please do not change the slide. Part in which cases and how long? We know very well the presentation by Amit was there, an excellent presentation by Amit. So part in which cases and how long? Sandeep, in your practice.
So in my practice, all those patients who are germline BRCA mutated or somatic BRCA mutated and who have responded well to platinum-based therapy as a CR or for that matter partial response, all those patients are eligible for PARP maintenance. Niraparib and the companion test is not available in India, but the data is supportive of using in patients irrespective of the BRCA, provided my choice score is there. I think its cutoff is 40, 41, more than that. So for me, all patients, preferably BRCA mutated, whether germline or somatic, are eligible for PARP maintenance treatment, which is available in India. as the time in the times to come, if there is availability of the companion test with the niraparib, the patients who have responded well to the platinum based therapy in the first line, all of them would become eligible for a maintenance PARP inhibition.
Any choice regarding PARP inhibitors? Preeti is yet to join, so it's you who can take it.
So olaparib is the choice. Reason being, this is the only approved therapy in the first line in the BRCA mutated patients. Though the cost is a prohibitive factor, and some of our colleagues, including me, are replacing olaparib with the rucaparib because of the generic availability. But as far as the evidence is concerned and data is concerned, olaparib is the drug of choice for such patients.
So olaparib is the drug of choice, but for convenience sake, some of us are using rucaparib as it is available and it is cheaper in the country. Do you want to state that, Sanjay?
Yes, sir. Right.
Any of my panelists differ, or any of my panelists would like to object to that? Any of my panelists?
No, that is correct that we do give rucaparib actually because of the affordability issues, and because of these medications are given for a long time, we must also pay attention to the toxicities created by these drugs like anemia or fatigue. But more or less, these are manageable toxicities.
So finally, Bhavna, just to complete the discussion, BEV plus PARP inhibitors like the Paula study, we have already discussed about it in a little back, which are the patients where we would like to use it. But Bhavna, your take on BEV plus PARP inhibitor?
Yes, this has it has become a very good, I will say, method of maintenance therapy for our ovarian cancer patients. And if you see the data of Paula 1 also, the patients who either had BRCA mutation or they had HRD status, both this group of patients derived significant benefit, and they have actually used bevacizumab along with PARP inhibitors. And the progression-free survival for BRCA mutated patient was almost 37.2 months vis-a-vis 21.7 months when the placebo arm was compared. Only thing that the patients who had HRD status, I mean, in the sense HRD not deficient, they're HR proficient. So this is the group of patients who will not benefit from this combination. So when we are using a combination which is expensive, which will add to the probably toxicities, it is very important for us to go for the right selection of the patient. And for that reason, we definitely need to do our testing properly. That is what I would say. But if there is a patient who is eligible, it is worth considering.
Well, coming to the next part, which is the platinum sensitive relapse, what we are talking about. Dr. Kakoli, would you use bevacizumab in your platinum sensitive relapse? And if you are doing so, how long you are going to continue?
Well, actually, I use it in a very limited setting because most of the times I use it either in the frontline setting or in the platinum resistant relapse in which the Aurelia data is there. So, very few cases, if there is ascites or extensive disease which without involving the GI, because we have to keep the risk of perforation in mind. So, with Gem-Carbo based on the Oceans data, very limited cases I use, and if I use generally, it is till disease progression, usually.
Okay.
And just to add to Dr. Bhavna, actually, I was listening to the BEV plus PARP inhibitor, if you don't mind.
Yeah,
so actually, in that, the one problem with the Paula data, even though there is a scientific rationale for the combination, I mean, there is a synergistic effect, but there was no arm with olaparib alone. So that's the thing, because both the drugs, it was bevacizumab versus olaparib plus bevacizumab. So there was no separate arm for olaparib. So we do not really know if, how much bevacizumab would add, because there is additional cost and additional toxicity. So what I do on the practical, on the ground is that I generally, for BRCA positive, I just go ahead with, because we generally do it upfront in the upfront setting. And I generally go with just olaparib, and HRD, I add bevacizumab. So that's what I usually do.
Okay.
So
okay. Nice.
I totally agree. I totally agree with you.
Thank you. Dr. Suman, PARP inhibitors in platinum sensitive relapse. There is a very good data on PARP inhibitors in platinum sensitive relapse. When do you intend to do PARP inhibitors in platinum sensitive relapse? How many cycles after chemotherapy? In which cases and how long? Dr. Suman?
Yeah, yes. Sir, as you already told, there is very good data, especially for relapse and platinum sensitive recurrence. So this is where we really have an advantage with PARP inhibitors, any of that. And personally, I don't even do the testing if they're platinum sensitive and they have a relapse. So just we can use PARP inhibitors independent of BRCA, because once they're platinum sensitive, it just means that they already have a BRCA. So we do use PARP inhibitors. How long I use is 2 years, and when do we use is roughly around 4 to 6 cycles, because most of the patients, when they relapse, they don't tolerate more than 4 cycles. So at the 4th cycle, I tend to start, and if possible, I go up to 6 cycles and then start them on maintenance.
Well, Amit in his presentation made a brief remark that if you have 4 cycles, after 4 cycles, if you see a complete response and you start PARP inhibitors, that's a situation. And after 4 cycles, you do not have a complete response. Would you like to add a few more cycles and then get a complete response and start PARP inhibitors?
So if you go by disease biology, I don't believe in that, because if they are going to respond, they are going to respond within 2-3 cycles. But then as studies goes, we can stretch it up to 6 cycles and then start.
Okay. But you would prefer to have a complete responder to go for PARP inhibitor maintenance than with obvious disease.
Yes.
Well, coming to platinum resistant relapse, which is a difficult to treat disease, has Chetan joined? Chetna Bakshi, has she joined? I don't think she has joined. Anyway, Mohit, you can take up both these things. Bevacizumab or PARP inhibitor in platinum resistant relapse.
If patient is having 3 or more line of therapy, then there is no data for comparison, but there is inclination towards the PARP inhibitor based on the data from the earlier trial. Just as we know in the first line setting, the bevacizumab had much less to the PFS benefit in comparison to PARP inhibitor. So if patient fulfill the criteria, then say it is more than 3 line or it is HRD positive, then I would prefer to use PARP inhibitor over bevacizumab.
Yeah. And do you think if the patient has received PARP inhibitors, say for instance earlier in a resistant setting, would you like to still use PARP inhibitors, or if it's not particular inhibitor, would you like to interchange to another PARP inhibitor? Do you think that it is doable, it is feasible?
So if you are talking about that the patient has received already PARP inhibitor and say she has progressed on the PARP inhibitor, then I don't think there is point of adding another PARP inhibitor and it is going to benefit. But if you were talking about the fact that patient is coming to me for the first time with the platinum sensitive, platinum resistant relapse, and I am supposed to choose between these 3, then as per guideline, I think there is hardly any difference, but there is some comparatively more data which favors some inclination towards the rucaparib. That's so data is slightly stronger in this setup, that platinum resistance setup.
Well, Sandeep, ovarian cancer and immuno-oncology, I think this is an area where immuno-oncology is yet to make a dent. Your thoughts on it? Is it for prime time use?
So even though ovarian cancer is considered to be inflamed tumor, but it is yet to show the immunogenicity that we see with other cancers like kidney cancers or lung cancer for that matter. Dr. Amit Agrawal showed very beautiful data. Immunotherapy alone, even though there is trial result from Keynote 100 which showed that there is a modest benefit with the immunotherapy with pembrolizumab, and the benefit was incremental with the more PD-L1 expression. But as on date, immunotherapy advice in the ovarian cancers per se in the resistant relapse refractory setting post 2 to 3 lines of chemotherapy, provided they are MSI high, that doesn't have a big role. So as on today, I think there is a lot more work to be done as far as immunotherapy is concerned in the ovarian cancers to get its foothold in the management of the ovarian cancers. Probably the use of the drug in the later lines, that is beyond 2nd, 3rd lines, when the body already have had exposure to the chemotherapy drugs, leading to the lesser immune responses to these drugs is going to play a part. The trial that Dr. Amit showed with the combination of the PARP inhibitor with the anti-VEGF had some beautiful responses, but alone as a drug, immunotherapy has failed to show give the enthusiasm that it has given in the other tumors. So as of today, I would say that immunotherapy doesn't have much role to play in the ovarian cancers.
Well, coming to body uterus carcinoma, I think the first question, again, I believe Preeti is not there, so I think I can ask Kapoli to take this question. Biological characteristics or markers you look for. I think the way things are moving on, I think we'll have to start doing NGS for most of our body uterine carcinoma. So what are the markers you are looking for and how to go about? Kapoli, and do you do it in your practice at this point?
Yes, generally we do, sometimes not exactly in the upfront setting, more so in the advanced setting.
Metastatic setting, yeah.
Yeah. So pole mutation and MSI, of course MSI is now part and parcel of the advanced setting. Even the pole mutation we are looking at nowadays, there is a panel, usually they have endometrial cancer panel, so we generally send all those markers in the panel itself, the endometrial cancer panel. And as far as adjuvant chemotherapy is concerned, stage 3, of course, we use it for all patients. Stage 1B and stage 2 in high grade, grade 3, we are using it as in our protocol. Mostly high grade, and sometimes in lymphovascular invasion or deep myometrial invasion, high risk patients, serous and clear cell we consider for all patients.
In fact, if you look at it, ovarian uterine carcinoma has in a short span of time changed from a surgical and radiation oncology dominated disease to again a systemic therapy dominated disease. What are your thoughts about it?
No, exactly. So in fact, now, with the, even though we are not incorporating all those mutations in the upfront setting yet, but I'm sure, in the near future, we would be incorporating the pole status and all those to decide, who knows, we might even start using immunotherapy first line. I mean, we might be using pembrolizumab first line, something like that. So, nowadays, of course, the local relapse radiation, I think will remain a part and parcel post-surgery, but soon the indication for chemotherapy or immunotherapy or targeted therapy as the developments, as the advances happen, will slowly be integrated, incorporated into most of the stages. I mean, it will probably become something like ovarian or ovarian cancer or breast cancer or something like that soon.
Well, Bhavna, endocrine manipulation, the use of CDK4/6, Susanna has talked about it. So endocrine manipulation in which setting? Do you have experience of using CDK4/6? I think it's not indicated at this point of time in use of uterine carcinoma. Your thoughts, Bhavna?
Sure. Can I just add a few things to the previous biological?
Sure. Please do.
So I think that, I do ask for MSI high even at the early stages of the disease. Sometimes makes us think that whether any of our patients is also part and parcel of Lynch syndrome. Now, many a times we are not able to derive any specific history from the patients, or we may not have, but we can probably have those patients put in for some kind of genetic counseling or screening if required, and we may find some patient families with Lynch syndrome also. So that was also one more thought which comes to my mind. Anyway, as far as endocrine manipulation is concerned, that yes, I do use it in my practice for some of the selected patients. Now, these are the patients who will usually have a great histology, a low tumor burden, and usually maybe from the previous therapy, a little bit long disease-free period. So these are the patients. We do have an indicator of ERPR positivity in this tumor, but it has been seen that even if the patient is ERPR negative, some of these patients do respond to hormone therapy. Up till now, we have been using megestrol acetate, tamoxifen, and those kind of things. And then now we have a data about everolimus and letrozole. which was compared with vis-a-vis with magistral acetate alternating with tamoxifen. And in that trial, it was shown that probably the response rates were almost similar, but the PFS on OS was better in the everolimus arm. So if at all you have a patient, you can do that everolimus with letrozole. Regarding CDK4/6 inhibitor, I personally feel that it's a very initial data, and I mean, I don't think that I'm using it. I'll still wait.
Okay. Okay. Dr. Suman, bevacizumab, is it really worth in uterine cancer?
Bevacizumab, there is a limited role, sir. As in any pelvic malignancy, after 2 lines, I have used bevacizumab, but generally for the first and second line, we practically don't use bevacizumab. And some patients who we have burnt our hands in patients who develop recurrence and they go for surgery. That's the point in which we don't really like bevacizumab in uterine cancer, because the bowel complications, even though it's said to be 1 to 2%, people who develop bowel complications, the mortality is 50%. So I really don't favor adding bevacizumab to patients who have limited metastasis.
Right. Right. Sorry. Yeah. So has Chetna joined? I believe she hasn't yet. So Mohit, you can take it. Immuno-oncology, is it useful in selected cases, and the way things are coming up, lenvatinib, pembrolizumab, how do you look at it? Now, these are not very easy combinations in our setup, especially because of the cost to be incurred for these patients. So how do you look at it, Mohit? Immuno-oncology.
I would like to say that not in first line, but of course in the second line onwards, if I find that MSI high or TMB high tumor mutation burden, then I might think about using pembrolizumab alone. And if I don't find MSI, that is MSS, then I would like to use Lenva Pembro combination, and we have used this in selected patients. Of course, the toxicity and the cost is the major concern. The Pembro is usually well tolerated, but Lenva is something.
It's a difficult drug to handle sometimes. Lenva is a difficult drug to handle sometimes. So,
yes,
so
that's
so
recommended dose is 20 mg. It's
which is very difficult. Which is
that's what I want to like. Lenva is difficult. So Pembro we can easily offer that, but Lenva is difficult to handle.
Okay. And Mohit, also your thoughts on, because nowadays we never used to look for HER2 amplification or HER2 overexpression in body uterine carcinoma. So do you think now we should look for HER2 overexpression in all these patients, and trastuzumab can play a big role?
Not for all, but for the patient with the serous carcinoma or carcinosarcoma, I would like to offer the HER2 testing upfront. And if I find that they are expressing the HER2 is overexpressed, and I would like to add trastuzumab to the traditional Paclitaxel carbo in the 6th cycle. And after 6th cycle, if I find finding the response, that patient is still responding, then I would like to stop chemo and continue trastuzumab till progression or intolerance.
Nice thoughts. Nice thoughts. Now coming to carcinoma cervix, I think this is another area where we have found that systemic therapy has come in a big way, and which was basically a domain of radiation oncologist in majority of cases. At least when we were students, we used to think that it's a radiation oncologist domain, except for early cases where surgery was considered. Now, Sandeep, adjuvant chemotherapy as a consolidation treatment after concurrent CTRT. Sudeep has alluded to the point in his presentation. So your thoughts?
So this is something which always creates a conflict between what I feel clinically versus what is the evidence for.
Right.
Okay, so since we know that most of such patients who are locally advanced CS cervix have more chances of a distant relapse, I have been using it in the practice in the past as well as currently. Those patients who are quite young has a good tolerance to the chemoradiation, and look performance status, good performance status. I use consolidation paclitaxel carboplatin for 4 cycles. However, if we go by the evidence, there are conflicting evidence. There was one Outback trial in which there was no 5-year overall survival difference, 71 versus 72%. There was a GLG trial, though they used a different protocol of gemcitabine with platinum concurrent with the radiation followed by adjuvant. versus one trial in which only it was used adjuvant, with more of the toxicity in which one trial showed benefit and another trial did not. But if we are discussing the clinical practice, yes, I am using the consolidation chemotherapy. The number of patients is not too much to be analyzed or published. But if I see as a clinician, there is a role of consolidation treatment to decrease the distant relapses. But if you practically theoretically ask for academic evidence, then I would say there is no evidence to give this treatment as on today.
Well, Sandeep, I'll just add a question to it. I understand we are very clear on this part. Now, Sudeep has also alluded to the point of neoadjuvant chemotherapy being not productive in this sort of a situation where neoadjuvant chemotherapy has been followed by surgery versus concurrent chemoradiation. Now, I'm giving you a different perspective. Do you think if you use neoadjuvant chemotherapy and thereafter use concurrent chemoradiation versus concurrent chemoradiation in this group of cervical cancer patients, do you think the outcome can be different?
So I would say
taking surgery totally out of the equation.
So surgery in any case for such patients is out of the question if they are locally advanced. The question is, neoadjuvant chemotherapy, as far as my understanding after discussion with the radiation colleagues, is leaves the chemotherapy resistant clones which are to be targeted by the radiation. Now, if we go with the principles of the oncology, the cells which are chemo resistant are usually radiation resistant as well. So we have already selected a resistant clone and are subjecting those to the radiation, which is unlikely to work. So neoadjuvant followed by concurrent chemoradiation versus concurrent chemoradiation when the bulk of disease is in the pelvis and there is no distant metastasis, concurrent chemoradiation followed by adjuvant chemotherapy, I would say I would favor more of the adjuvant chemotherapy part rather than the neoadjuvant chemotherapy part.
Okay. Coming to Bhavna, routine testing of MSI or PD-L1 in recurrent metastatic cervical cancer. Your thoughts?
Yes. And just to add to the previous question, actually, because that we don't have data for the role of adjuvant chemotherapy, I generally avoid giving the adjuvant chemotherapy, and probably we can keep those drugs in reserve because some of these patients will probably come back in future with the disease. So that's it. And regarding the routine testing of MSI and PD-L1 in recurrent and metastatic disease, so now with more and more data, which seems to be stronger for the use of immunotherapy in CS cervix, we have now started doing it in our hospital. But maybe because a couple of years back we were not doing it, but now more and more data is coming. And if the CPS score is more than 1%, then probably we can offer our immunotherapy to these patients. And that is where we stand today.
Okay. Dr. Suman, the final question. Addition of immuno-oncology to current regime.
We saw the last presentation by Dr. Sudeep Gupta that there is promising result of adding pembrolizumab to current regimen. So, where in cervix it's indicated is recurrent metastatic or persistent disease. So, if as ma'am told, if the CPS score is more than 1%, then we can definitely add pembrolizumab. The same way that bevacizumab had very promising results in cervix compared to any other tumor. I think immunotherapy also will have because cervical cancer itself is immune driven. So I think it will have a promising addition to chemotherapy if patient is affording the same.
Well, wonderful having discussion with all of you. I think we are coming to the close of our panel discussion. I would just take 1 minute and give each of my panelists a moment to say, what do you think is the present role of a medical oncologist in gynecological malignancies? I understand it was almost non-existent other than ovarian cancer in these three settings. What do you look at medical oncologist's role in the treatment of uterine cancer, ovarian cancer, and cervical cancer? Each one of you for a minute. I can start with Bhavna.
So I think we all know now that our role is very important, day by day increasing, and the same time our responsibility increases because we need to be keeping ourselves updated by all the new data which is coming and selecting our patients correctly for all the treatment. That is what I look at it.
Dr. Kakoli?
Yes, I agree with Dr. Bhavna. I think we have a very big role to play now. Ovary was always there, but in uterine and cervix, like I mentioned before, that slowly the indications are expanding, and with the advent of immunotherapy, likely to be incorporated even in the curative setting in the future, if trials show good results. So we should be updated, and we should select patients well, and so that we do not miss anybody, who would benefit from this treatment, and that would give a longer survival. Just one point I wanted to add about the neoadjuvant. Actually, we do, in our setting, because you asked that question, in cervix, we do use it actually occasionally in patients who have bulky nodes, pelvic para-aortic nodes. We do use it for 2 to 3 cycles. And especially in the adjuvant, we sometimes consider it in adenocarcinoma of the cervix, because those cases generally they do not really fare well. So I just wanted to add at that point.
Sorry to interrupt, but we are running short of time.
Yeah, we are closing. We are just closing. So I think we'll close at this point of time, since we are running short of time. And when you said that ovarian cancer was always there, I remember those days when ovarian cancers were treated with adriamycin, endoxin, and platinum. So we have come a long way from that part. And I think I thank all of my panelists for being very, very vocal and saying, taking this panel discussion to a greater height, and followed it up. And especially when those 3 speakers have spoken, it was very difficult to maintain that standard in the panel discussion. And I thank you all very much for being an excellent panelist. And I thank the organizers for giving us this podium. Thank you very much. Over to the chairperson, please.